So now we move on to next presentation by Dr. Suneeta Dubey. We know she is a glaucoma expert from Shroff Charity Institute, New Delhi. And we know that microinvasive glaucoma surgeries are coming up, and she has been doing variety of microinvasive glaucoma surgeries. So if cataract is there, we need to combine, and we do combine cataract with MIGS. So now let's see what Dr. Suneeta Dubey will be telling us about MIGS and cataract.
Okay, thank you, Shalini. So MIGS and cataract options. So now we have wide range of surgical options with development of these large area of novel minimally invasive glaucoma surgeries. And compared to traditional surgeries, we know that there are fewer risks, fewer complications, and faster recovery time. And most importantly, they can be combined synergistically with cataract surgery. The results are much better with cataract surgeries than standalone, and they reduce the medication burden and improve the quality of life. So they can be used either as surgical device that incises, excises, or ablates the TM, as in GAT, KDB, and trabectome, or they can be used as an implant, eye stent, and hydrus, and basically they increase the aqueous flow through the conventional pathway. So now coming to the indications, normally we use MIGS after exploiting the options of medications and laser. However, if we are performing cataract surgery, then we can do MIGS, especially in mild to moderate glaucomas, or if the patients are not compliant with the drops or they are intolerant to the drops, even in advanced glaucomas also. And I have found now, as we gain more experience, I found that you can use them in secondary glaucomas also, which are not very long standing, along with or without cataract surgery. So the position and setup of the microscope is very important. The microscope is tilted towards you around 30 to 35 degrees and head of the patient away from you, so as to make an angle of 70 degrees. Here, it's very, very important to have an en-face view of the angle to perform the angle surgery precisely with using the Swan-Jacob type of surgical lens. So you have to have a very clear view of trabecular meshwork and the other angle structures, and then you can do your procedure. So the advantage with this excisional goniotomies is that they excise the TM completely, and therefore the chances of rescarring and reocclusion of the collector channels are pretty less. So we started with this trabectome in 2019. It's a machine standalone device with a plasma mediated ablation system, and the advantage with this is that you have an inbuilt irrigation and aspiration which maintains the AC stability and increases intraoperative visibility. So you just engage the TM and then start ablating on one direction along the arc of Schlemm's canal without, you should not have any resistance, and as you keep moving your gonio lens, then you can target around 140 to 150 degrees, and then you can perform your phaco after that. So it can be very nicely combined with cataract. So this was the paper which was published last year about the outcomes of trabectome in primary and secondary glaucomas, and we had 58 eyes who completed 1 year, and the success rate of phaco with trabectome was 88%, was discernibly high than trabectome alone, which was 67%. So combined MIGS with cataract have very good results. Another procedure is Cahoog dual blade, and this is a sharp, this has a sharp tip which pierces the TM, and the ramp lifts the TM and feeds it into the dual blade like this, and the heel nicely rests into the Schlemm's canal. So there are no collateral damage. So this is the procedure, this is the blade, and you introduce it, engage the trabecular meshwork, and start excising it in one direction, and you can see this TM nicely coming off. So you can just keep rotating your gonio lens, and you can just get this strip removed later. You just turn it 180 degrees in the opposite direction and do it on the other side. So you then later on remove these strips on either side. So this will help in re-occlusion, and then you perform the phaco surgery after that, after removal of this. It's not, it has got stuck. So, okay, so after that you can perform the cataract surgery after removal of the strip. It's very important to elicit this episcleral fluid wave. So after finishing your surgery, when you inject fluid through the side port, you see this blanching of vessels here, which is suggestive of patency of the distal collector channels. So here the vessels have blanched. So that means the distal collector channels are patent. And these distal collector channels are maximally located on the nasal side where we perform the procedure. So I'll just like to discuss 2-3 cases. This is 11-year-old child who had a history of blunt trauma, and he also had traumatic cataract along with very high pressure, and which was intractable, not controlled with medication. So I decided to take out, because it was a kind of total cataract, so I thought of doing phaco KDB in this child. So before taking out the cataract, the KDB procedure was performed, and you can see a nice cleft because the angle was open. And then after completion of cleft, the phaco was performed. So this child even had a pre-existing rent because he was a patient with trauma. So after doing thorough vitrectomy, 3-piece PCIOL was inserted, and the child is now doing very well. The pressure is controlled with the procedure, and you can see a cleft also post-operatively. So this procedure is important, is very useful in patients who do not have very long-standing glaucoma. This is another patient who had high pressure post-trauma, and he was again not controlled on medications, and he had ruptured cataract. So again, I planned removal of this lens material along with the goniectomy procedure. So again, the angle was open and the cleft could be created here. And then after removal of lens aspiration, the lens was put in sulcus. So he is also doing pretty well. So all these patients of secondary glaucoma have realized that can be treated with these procedures. Another patient, KDB, was performed after incisional glaucoma surgery for secondary glaucoma. So this patient had post VR surgery intractable glaucoma, for which tube implant was done. The tube was nicely in place. However, she developed total cataract after a few months. And then along with cataract surgery, goniectomy was also performed. She is now on maximal tolerable topical therapy because she had intractable glaucoma. GAT, cataract surgery can be combined with GAT. So again, I prefer to do procedure before cataract surgery because when you perform these procedures before cataract surgery, the eye is not hypotenuse and the visibility of angle is very good. So this is the procedure being performed, and you introduce this mushroom-tipped Prolene suture in the Schlemm's canal, 360 degrees. And then suture is pulled externally and withdrawn from this section, and then you can perform phaco. Last but not the least, Eye stent also is more effective when it is done along with cataract surgery. So we are using two generations, generation 1 and eye stent inject, and it comes with this pre-loaded injector. So here the cataract surgery is performed first. So after doing cataract surgery, you just constrict the pupil with pilocarpine. So this is generation 1 eye stent, and this SX lens is being used here. So here it's very important to have an en-pass view of the angle, because you have to insert the implant into the trabecular meshwork. So once you have done it, just check that it is nicely placed, and then you can close the section. So here another eye stent inject. This is the eye stent inject. Here you have two eye stents. So here you have to put the implant through the injector. So you just press the trabecular meshwork, dimple the trabecular meshwork, and just push the black trigger button to implant the stent. So first stent, and then move 2 to 3 clock hours away, and then insert another one. So to summarize, MIGS are not so potent as the trab and tube implant surgery. However, they are safer options for the patients, eliminating the need for resorting to more invasive glaucoma surgeries, which you can reserve for the future, because they don't have any impact on the success of future filtering surgery. And very importantly, when you are performing cataract surgery, you can perform MIGS with good efficacy. It will reduce the number of medications, improve the quality of life. So with judicious selection of cases and MIGS, glaucoma surgeries now can be individualized according to the age of the patient, stage of the disease, and nature of glaucoma. Thank you very much for your kind attention.
Thank you so much, Dr. Suneeta Dubey, for such a wonderful talk on MIGS. So she very nicely showed us that how can we visualize the angle of anterior chamber. So in most of the cases you were using gonioscope handheld.
Yeah.
So we also have availability of non-hand, we can directly hold the gonioscope. So what is the difference between the two? And which one should
that's
prefer?
hands-free gonioscopes,
Yeah.
because it may be sometimes difficult to use all your 4 limbs, like both the hands and, with the
Yeah.
phaco
Yeah.
probe and microscope foot pedal on. For the beginners, I would say if your one hand is free, then you can have better manipulations.
Yeah.
But I think with practice, it doesn't make that much of a difference. And because I started with the handle one swan Jacob type.
Yeah.
And I'm very used to that, and you can keep rotating the lens, although it is not very wide field lens, as now we have disposable lenses which are wide field.
Yeah.
They cover almost the entire cornea, and the magnification is pretty good of Catena lens and SX lens. But the Swan Jacob, which is of Vogue, doesn't have that much of you don't get so much magnified view unless you increase the magnification of the microscope. So that can be uncomfortable, especially for the beginner, to operate under such high magnification. So, but over a period of time, I think one gets used to it. But yes, hands-free gonioscopes are also available. I think you can ask Swati also what she uses.
Dr. Swati, what do you use?
I also use with the handle, because you need a very cohesive viscoelastic for the SX prism, that the Eiffel Tower one, to stay on the cornea. If you use normal HPMC or Oragel or a lesser cohesive viscoelastic, it just slides away. So you want the angle to be under your control. So I use with the handle.
So any other experience, Dr.
Ocular lens is also a good lens that has got the flanges like a contact lens. So it kind of covers your side ports and does not allow egress. And hands-free in a way is good because you can use the other hand to press the limbus, so it opens up the angle more. So it gives a little better view, although I've learned most of it from Swati only.
Yeah, I agree. Hands-free gonioscope are also a good option, especially for the beginners. Dr. Shweta, would you like to comment?
Yeah, as Swati very correctly said, the minute you start practicing, your hand, it doesn't actually matters that your hand is engaged in seeing that particular angle, because always the angle should be under your control. So what you can do, as ma'am suggested, use your left hand for fixing the lens over the cornea and magnify. What I do in my surgeries, I change the magnification with the microscope tilting, and that's how you can get a clearer view of the angle, and that's how we can go ahead. Ma'am, I've got one question for you. Can we suggest the case of phacoIOL along with bang under topical anesthesia? Have you, what is your experience? PhacoIOL, bang with topical anesthesia. Your experience in that? Like, how is the cooperation level? Because in this particular thing, we are tilting the head of the patient. We are doing so many manipulations. So what is your experience in that?
I think the patient selection, especially for the beginners, is very, very important. You should be, I think you should be able to assess the systemic status of the patient also. The patient should be able to follow the commands. And maybe I think it is better to give or instruct the patient pre-operatively only what you are going to do, whether you are going to tilt the head and how much, and the patient should not have any neck stiffness or any systemic condition which can restrict or which can be a constraint to your procedure. But initially I would say that I think it is better to do under anesthesia, because sometimes under topical the patient keeps moving the eye, and if the pressure rises, then there will be a constant iris prolapse through the incision that can also be there, especially if the patient is anxious. So I think one needs to take due care in making the patient comfortable. The patient should be comfortable in tilting the head also and remain in that position for at least 5-10 minutes, whatever time. So I think that patient
I think we should assess pre-operatively, like for all topical anesthesia surgeries. We need to assess beforehand and then proceed for the surgery.
I want to ask one question, ma'am.
I'll just add, like, if you're doing under topical and it's such a high magnification, slight movement of the patient's eye or head, everything will just go out of the field. So you need to recalibrate everything again, because it takes more time to kind of settle the things than to do a surgery per se, because the surgery will take few seconds. But
I think
setting
the
up,
surgeon and the patient both should be comfortable.
the setup is more time taking than the surgery per se.
Cooperation becomes very, very important for good visualization.
And just addition to everything, if you are planning to do like any angle surgery, even after your cataract surgery, and you feel that your chamber is not fully formed or any hypertonus effect you are getting, probably you can put a suture, and then that will tighten your globe. Later on, you can remove that suture after performing your angle procedure. That's a take.
So that is the advantage of doing angle procedure before cataract surgery, that you can make a very small incision and do the procedure, and your angle is untouched. You will not get that blood reflux in the angle, which can hamper your performance of the procedure.
Ma'am, what post-op regimen do you normally use for all your MIGS plus cataract?
Steroids, antibiotics, and I also do give pilocarpine for 2 weeks HS in most of the
how
patients.
do you taper the steroids, ma'am? Like 7 days taper or?
Yeah, taper in the usual
Normally
way
what we do for cataract.
As cataract, unless there is some excessive inflammation or hypema or something like that.
And ma'am, do you stop anticoagulants before
Yes,
doing?
yes. Pre-operatively anticoagulant should be stopped.
Always a detailed history of using of any anticoagulants is definitely required in all these angle procedures.
Yes, I think that should be done.
Ma'am, yesterday we were discussing that steroid response after MIGS plus cataract is more and earlier than in cataract surgeries alone. Have you come across any such situation where you also feel that the steroid response in these cases post-operatively is earlier or more aggressive?
So I think you are sometimes not very sure. I don't give very potent steroids. What I do is I give dexamethasone for 2 weeks and then switch to lotipred after that. But sometimes I have seen in some patients there's a spike. So I think there can be a steroid response. So you have to give anti-glaucoma drops to those patients.
For 1 week or 10 days.
But I have seen, like, especially with KDB, I have done 60, 70, 80 KDBs as of now. So for the initial 3-4 weeks, there is no spike in the pressure in most of the patients, unless there is steroid response or there is very high inflammation in secondary glaucoma patients. But otherwise, in mild to moderate POAGs, the pressure reduction is pretty good.
Thank you so much,